I've now started chief residency at UAB and I've had a couple months of attending, which has been wonderful, working with residents and medical students, which has been great. But have been very busy with scheduling and working with them. So I'm glad to be back with you guys and talking about my favorite topic ever with one of my favorite people ever, GI and Emma.
Hi, everyone. I similarly have been not on VMR in a while. I'm Emma Levine. I'm a second-year internal medicine resident. I'm super excited to be here with Lindsay and everyone else.
We are looking for 2 volunteers to discuss some cases with us, and cases is yes, plural. So we will have 2 cases tonight. Both of them will be short and kind of comparing and contrasting the 2 different cases, but I won't give away the topic yet, but it'll be given away pretty soon. So are there 2 people that want to discuss with us? Please put your name in the chat. Otherwise, me and Emma will be presenting the cases and then kind of acting as the discussant on either end. And Emma, you want to introduce your puppy while we wait for some discussants?
Sure. This is my actually my boyfriend's dog, Ollie. He's a golden doodle. Ollie, can you say hi? No, he cannot say hi. He loves to eat. He's very food motivated and lounge around and cuddle.
Awesome. Still looking for 2 discussants. It's okay if you're interested in GI, great. If you like to hear more about GI but don't want to do GI as a career, totally understand that too. You don't make Ollie have to discuss. That would be great. It'll be a lot of fun, I promise. All right, we already have 1 volunteer, Drew. Anyone else? I can sit here in silence all day long. We don't want to do that though, because we have a lot of great teaching and a lot of great, 2 great cases to learn from. Mario, awesome. All right, Drew, Mario, can you guys unmute yourselves and introduce yourselves?
Hi, everyone. I'm Drew. I'm a PGY1 in Med Peds at Western Michigan University School of Medicine up in Kalamazoo, Michigan. Was just on Unremarkable Labs, the other of Lindsay's responsibilities, last week discussing a Med Peds case. And on my last month of Peds stuff before I come back into the IM world. So figured I need to get back into a little bit of adult management.
Awesome. Welcome back. Mario?
Hi everyone, my name is Mario. I'm a 6-year medical student from Lima, Peru, and I would love to discuss cases. Really, always a joy. So happy to be here.
Awesome. Well, thanks for being here. We're excited to have you both. All right, we can get started with Emma's case first, and then okay, Drew, do you want to go first on this one, and then the second case will flop? Mario can go first on that one.
Works for me.
Okay, perfect. And I will be discussing with you both, and Emma will be presenting.
Awesome. All right. So chief complaint is dysphagia. So this is a 45-year-old gentleman with no significant past medical history who presents for evaluation of dysphagia. He has a 3-year history of intermittent but progressive difficulty swallowing solids and liquids. Previously, he managed his symptoms by drinking water to flush the food down. He also drank a lot of carbonated drinks and would have to sleep with the head of his bed elevated. He does not choke or cough with swallowing. 1 week prior to presentation, he began to feel more unwell with worsening dysphagia and regurgitation of undigested food, chest discomfort, and decreased PO intake. He denies fevers, chills, night sweats, unintentional or unexplained weight loss, exertional chest pain, shortness of breath or dyspnea on exertion, orthopnea, neck pain, no nausea, abdominal pain, diarrhea, constipation, hematemesis, adynophagia, melena, hematochezia, recent trauma, or travel outside the US.
All right, Drew, give us some of your initial thoughts.
Oh boy. So we have a 45-year-old gentleman who doesn't have much of any significant prior history or any other things that are going on with him, who's coming in with, and let me just clarify, Emma, it's 3 weeks of this, or how long has this been going on?
So he's had a 3-year history of intermittent but progressive difficulty swallowing, both solids and liquids. But within the last week, he's just felt a little bit more unwell.
Okay. So this has been going on so this is chronic, intermittent, worsening dysphagia to both solids and liquids. He is still able to drink, and I presume is still able to eat, but he's having worsening regurgitation of undigested foods. It's interesting that he says that drinking carbonated liquids helps. That's something that we typically think about when we have someone who has gastroesophageal reflux, where sort of the carbonated, or at least the carbonation helps with sort of, it sort of feels better to the tongue than just plain water. But for me, I'm starting to think about, if this has been going on for the past 3 years, I wanted to think way further back. Like, has he had any sort of issues with like metallic tastes in his mouth, or any history of smoking that could cause a slower growing mass. He doesn't have anything that would indicate any sort of major inflammatory disease. But then again, if this has been going on for the past 3 years, any inflammation that exists would probably be subacute, if at all. Yeah, at this point, I'm thinking about looking for causes that have been a bit more longstanding in the past 3 years, and looking at risk factors that would increase his risk for something like an esophageal cancer. That's where I am so far.
Yeah, great. Excellent job, Drew. And I think, dysphagia is one of those where whenever I hear dysphagia, the first thing that I like to do is clarify, is this dysphagia or is it something else? And I think that first branch point for me is it dysphagia or is it adynophagia? So some people confuse dysphagia with adynophagia. And adynophagia means pain with swallowing. And then dysphagia just means difficulty swallowing. So sometimes I'll even simplify it and I'll say, does food get stuck and where does it get stuck? Sometimes if people will point up here in the oropharyngeal area, they'll point at the suprasternal notch, or they'll point way down in the epigastric area. And so I want to know where they feel like the food is getting stuck, or the food or the liquid. So those are 2 big branch points that I ask right off the bat. And then, whenever a patient like this says intermittent progressive difficulty swallowing solids and liquids, my next branch point is which one happened first, or did they both happen at the same time, right? Because that kind of helps me determine, is this more of a structural issue? So exactly like you were saying, Drew, you're worried about a malignancy, you're worried about a smoking history. So is this something that was small and there were issues with food and then progressed to liquids? And so something that's enlarging, whether that's a mass or something else, either inside the esophagus itself or external pressing in on the esophagus. And you have a lot of structures in this medial sinal area that could be causing that obstruction. So, but it looks like, based on what Emma's telling us, that swallowing solids and liquids might have happened at the same time, but those are just some extra questions that I would ask him just to be certain. And, you know, if the patient, going back to the localization, I will say that sometimes localization helps you and sometimes it does not. If somebody says food's getting stuck in the back of my throat, that's helpful. If somebody says food's getting stuck way down here in my epigastrum at the base of the sternum, that's helpful. But if somebody says, I don't know, somewhere here, kind of between the bottom of the neck and then to the suprasternal notch, sometimes that cannot be helpful. Sometimes that can be anywhere from oropharyngeal to esophageal, and you really can't tell, and you really need to just get maybe 2 studies to try to figure out where your localization is. Other thoughts? Yeah, I don't know what to make about the carbonation. You know, it is gas producing, and sometimes maybe that'll help open up the esophagus to get food or liquids or something down further. But very reassuring that he doesn't have any of the B symptoms or anything else that's alarming going on. But great job.
Yeah, and I just like to emphasize that in the description of the case, it says that the patient has drank liquids to sort of help with swallowing. So as Vivek noted in the chat, it seemed like swallowing liquids was at least a little bit easier at first. So I'm starting to prioritize. So I'm starting to think that this was solid before liquid dysphagia. So I'm starting to prioritize mass first over a pure motility issue like an achalasia or something like that.
Cool. All right, Emma, what we got next?
Awesome. So in terms of past medical history, as mentioned, really no significant past medical, no significant surgical history. He's not taking any medications, just some over-the-counter supplements, no allergies, and no like family history. In terms of health-related behaviors, he drinks occasionally, like when he goes out with friends, no tobacco or recreational drug use, and he works in tech. Since it doesn't really add too much, I'll probably just go on to the physical exam.
Cool. And then any like, did he tell you any of those other things, like where it got stuck, or if it was solids and liquids together or solids and then liquids? Did he tell you any of that?
Yeah, so he said that it kind of like, it was not like the process of swallowing, like it's not like when food was in his mouth, it was kind of like later on, as Lindsay, as you had mentioned, more like kind of the esophageal area. He couldn't really clarify which one came first. In terms of physical exam, he's afebrile, normotensive, and in no acute distress. He has moist mucous membranes. Cardiac exam is regular rate and rhythm, no murmurs. He has no JVD or lower extremity edema, and his lungs are clear to auscultation bilaterally. His abdomen is soft, non-tender, and non-distended, no ascites or organomegaly. And then for labs, lab is really notable for a mild normocytic anemia. All the results of the CBC and CMP are otherwise within normal limits. He has a negative trope and a negative BNP. And he had an EKG as well that showed normal sinus rhythm with no ischemic changes.
Okay, Mario, what do you think?
Okay, so I also think on those same buckets in terms of dysphagia. I also begin distinguishing between oropharyngeal and esophageal. And when we are in esophageal, is this a primary a motility disorder or a structural problem? And I think the fact that this has been what appears to be simultaneous solid and liquid dysphagia, I would prioritize a motility disorder. Maybe I'm wrong in that. And I think the first thing that comes to mind when thinking about a motility disorder in this case is distinguishing if this is a primary or a secondary disease process. I think the travel history is important, or the lack of travel history is important. Here in Peru, Chagas and Trypanosoma cruzi, it's a pretty, I wouldn't say common, but it's endemic, especially in the south from Lima. And you can get secondary achalasia from that. Also, you can get, I think it's called pseudoachalasia from esophageal adenocarcinoma. So I also agree we should be prioritizing to not miss that type of cancer. But the other point would be if this is a primary process, like a primary achalasia. I think symptoms are compatible with that. And I don't see any like alarming red flags, especially no smoking history and stuff like that. So I think that those would be my initial thoughts.
Yeah, that's great. I love how you break down dysphagia and your approach. I think having an approach to dysphagia and knowing when your branch points are so important, because the differential for all of those branch points are completely different. And right now we don't really know if it's motility or structural. The patient can't really, tell us that. And we can only presume or hope that it's not cancerous or not some large mass, right? Because you're mentioning all of those risk factors that we would be worried about that maybe he doesn't have, right? He's not anemic. He doesn't have any B symptoms, no weight loss. So we're just kind of hopeful that it's not malignancy. I think at this point, we can kind of see, he does have mild normocytic anemia. So take that back. He does have some anemia. So maybe there is some kind of lesion in the esophagus, or maybe even lower down, that's causing some slow bleeding that he's not seeing in his bowels, and he's not having any vomiting. I think the next step is probably trying to figure out, right, which test comes next. And there's a lot of different tests, I think, in GI that you can do for dysphagia. And so I want to spend a couple minutes just talking about those tests. And so whenever I think about dysphagia, the reason why we try to localize early with our history is because if it's oropharyngeal, you're thinking, I want to call my speech pathologist, get a modified barium. And then if you're even thinking about something really acute, is there a stroke, and do I need to pursue some kind of brain imaging? As opposed to if you're worried about something lower down, do I need to do a full barium esophagram, or do I need to call gastroenterology and see if they'll do an EGD to try to help us figure out what's going on? And I'll say that different GI doctors prefer different tests first. And one thing that has been pretty consistent in the GI doctors that I've worked with is a lot of them, if there is some concern that the anatomy may be different, so somebody's had some radiation, or somebody's had some surgery, or something around the mediastinum or to the esophagus itself, that's when they may prefer a barium swallow first in all cases. Otherwise, most will pursue an EGD first. And another thing, did anybody know that there's a single contrast barium esophagram and then a double contrast barium esophagram? I'm checking the chat real quick too.
No.
All right. Somebody said air. Can you unmute yourself and tell me what you mean by air? If you can't, that's okay.
This
Yeah,
is good. I think sometimes people, when you have air along with barium, that acts as a second contrast. So that's what I thought could be the case.
That's exactly correct. And so a lot of institutions will go ahead and default to that double contrasted study. And so that the double contrast, the first is the barium, which is the liquid, and the second is the gas. And the thing that the gas does is it helps open up the esophagus, because otherwise it's a flat tube, right? And when you put gas in there, it'll open it up, and so you can better see smaller mucosal lesions. Now, if you have a large mass or a large stricture, or even some other large pathology, a lot of times barium is all you need, but a lot of institutions will default to doing the double barium, and you order it, and that's just something that you order. But just kind of be aware in some institutions, like at our VA hospital, there are two separate orders. And so you kind of have to be thinking about what you're looking for and figure out if you want a single contrast or a double contrast. And the single contrast is better for your larger abnormalities, your strictures, and then the double is better for smaller mucosal issues. So this can be Dhruv or Mario. What test do you guys want to start with first? Or you both can comment and say what you want to start with first.
Well, I think this probably goes back to what we were saying, what we're expecting to find. Like if we're expecting to find a big mass or maybe a small lesion. In this case, I didn't notice the anemia, so I think that's a very important clue. It would be important to know, maybe you have past CBCs to know if this has been long-standing or recent. But assuming the worst scenario, maybe we should be worrying about a neoplasm there. I'm not sure if this were maybe a bigger lesion, maybe the patient would have presented earlier. So maybe this is a small lesion, and maybe the best would be a double contrast, but I'm not exactly sure.
Yeah, I'm thinking the same of a double contrast barium esophagram, and then what's likely going to be the next test afterwards, if we find what we expect, would be an EGD and then a biopsy of the area to see if there is a mass, what is it?
Perfect. All right, Emma, what happened next?
All right. He did undergo a barium swallow that revealed a markedly dilated esophagus with a maximum diameter of 8 centimeters. Normal for reference is 2 to 3 centimeters. The esophagus had a sigmoid configuration, and a large amount of retained food and secretions were noted. There was considerable narrowing at the GE junction and very poor esophageal emptying.
Swerve. So that's achalasia, pure and simple. Huh.
That does sound like it. Mario, thoughts? You agree with that diagnosis? I think you're frozen. Yeah, so whenever, I think about achalasia, it's, that bird beak narrowing, right, is the stuff that we learn for our exams. But achalasia, there's actually 3 different types. And I'm not going to go into all the types because honestly, I don't know all of the types yet. Maybe next year I can come back and tell you all 3 of the types. But there's 3 different types, and not all of them have that same bird beak appearance with the dilated upper esophagus. So a lot of times what you do for patients like this, if you do an EGD and there's no mucosal abnormality, you have to go for manometry, and you have to see what actually the muscle is doing throughout that test. So I think this is Mario. You're not muted anymore. I don't want to take away. Go ahead. I mean, you're not.
No, sorry. Yeah, I think my connection lost. No, I really just was thinking about the same thing, but I don't have anything to add really.
Okay, awesome. Did this patient undergo manometry to confirm, Emma, or was this enough to?
He actually underwent EGD that revealed a large amount of food in the esophagus with friable esophageal mucosa, patchy erosions in a vessel with a clot that they injected with epinephrine. He had to undergo 2 EGDs actually to help remove the food bolus. And they dilated his lower esophageal sphincter. And he eventually underwent an esophagectomy, which he tolerated well.
Wow, and this was thought to be due to achalasia?
Correct, primary achalasia, yeah.
Wow. Cool. Thoughts, guys?
Dang. It seemed it was interesting that, well, I would have thought that, with the I guess, solid, with solid close-ish to liquid dysphagia. I guess achalasia should have been a little bit further up the top of my differential than I initially had it, but I guess I was thinking to myself, well, if he's able to get solids down, and if the liquids were starting to go down, were going down easier before this last couple of weeks, then maybe there's a larger growing mass. But
Yep. Mario, any thoughts before we go on to the next case?
Yeah, or just do you realize that the fact that the food can get stuck, that can cause erosions and complications secondary, not to the primary disease process, but by the accumulation of food. So that's something I never had realized. So it's cool, nice to learn new things.
Yeah, great point. Great point. All right, let's move on to the second case. And then Mario, you'll go first this time. All right, so I have a 65-year-old female who's presenting with dysphagia. She actually presented to the ER with a single episode of substernal chest pain, non-radiating. It was lasting a couple days, came on, progressively got worse, sharp. And then when you asked her a couple more questions about the chest pain, she also mentioned 2 months of dysphagia. And for this dysphagia, she said it was in the beginning only solids, and so she was chewing up her food a little bit more into smaller bites, but now she's having difficulty with liquids.
Okay, so maybe I'll start. I think most of the times when we have when you think about acute chest pain, we've used a 4-2-2 algorithm, and I think I've never actually thought about the two esophageal causes. Usually it's the cardiac or the pulmonary. So in this case, I would be thinking about the latter two. I'm thinking we're esophageal impaction and esophageal rupture, and I would add here esophageal spasm. That's not so morbid as the first two, but I think that we think about, in this case, about dysphagia and chest pain. I think those would be three things that I would keep in mind. The fact that it's like an acute on chronic, like an acute process on a chronic background of dysphagia to first solids and then liquids make me think of as we have been talking about more like a structural issue. So I'm thinking maybe there's a structural anatomical process that has caused and in this acute stage an esophageal impaction causing this acute chest pain. So I'll be thinking structural, complicated maybe by some type of impaction.
Mario, I loved how you started with like what her her chief complaint was, which is chest pain and not so much the dysphagia. And then you narrowed within that kind of, as you mentioned, like kind of that framework of like the emergencies that we think of within chest pain, and focused it on the overlap between that and the dysphagia symptoms. So I think that's super helpful for us to kind of narrow down both the chest pain as well as the dysphagia. And I absolutely agree with you with solids first, then liquids. I am thinking of like an esophageal etiology with a structural component of it.
Awesome. So past medical history, and then sorry, I forgot to mention this. She did have 10 pounds of weight loss. And then past medical history, she has type 2 diabetes, hypertension, reflux, and tobacco use. Her blood pressure was 167/80. The remainder of her vital signs were within normal limits. Her physical exam was completely normal. And I'll stop there.
So, decent number of risk factors for malignancy with the acid reflux, tobacco use. The weight loss is interesting, and I wanted to clarify, Lindsay, and I think Ramla in the chat is asking the same question. How long has this weight loss been going on for? Is it been around the same time as the dysphagia started, so about 2 months, or has it been going on for less than that?
Yep, 2 months.
About 2 months. Okay. So could this just be the fact that she's not able to, that because she's not taking in as much food, that she's losing this weight? Maybe. But we also have to think about whether or not a growing mass may be accelerating this weight loss. And we just aren't seeing it yet because it hasn't been going on for that long. This again is pointing me towards esophageal cancer. It's with maybe a complication of an impaction, considering that this patient has had substernal chest pain, and that's something that we want to make sure that we're ruling out right now. I think the only other thing of note is that hypertension. I mean, it could just be that her 167/80 is just where she lives, blood pressure wise. I'm not sure about her medication history and whether or not she's been taking her taking either A, taking any antihypertensives, or B, taking her antihypertensives in the manner that was prescribed. And otherwise, vitals normal, physical exam normal. If we've caught an esophageal cancer early, we've caught it pretty early with this. I would say the next step for, again, would be probably barium swallow and then EGD, EGD for her.
Yeah, I think, Drew, you've really highlighted some of the key points of like her weight loss, her history of acid reflux and tobacco use. And actually quickly going back to the HPI, Lindsay, were her dysphagia symptoms, it sounds like, or just to clarify, was it like acute, intermittent, or progressive?
It was progressive.
Okay. So I think I agree both with Drew and Mario. When I think of like the symptom kind of time course, when I think of like acute, I think more like foreign bodies, and intermittent, I'm thinking of like spasms, and then progressive, if we're in that structural category, thinking of malignant neoplasms being high on my differential and definitely a can't miss. I think for someone like this with structural, I would probably go with an EGD first, but I'm curious to kind of learn more about her case.
So she did go through an EGD first, and well, let me tell you the labs first. So CBC normal, BMP normal, troponin negative, EKG, normal sinus rhythm, no ischemic changes, and chest X-ray negative. And then the EGD showed normal mucosa, no abnormalities.
Mario, any thoughts?
Well, I think we were expecting to find something in the mucosa, because I think our pretest probability for a malignancy was pretty, if not high, at least moderate. So that's reassuring. I'm not sure if it's completely sensitive to or rules out completely a malignancy, but surely lowers the probability. So if there isn't, if what other things were on our differential, because we were thinking about particularly structural problems, so diverticuli or webs and rings. I think that would be noticed on a EGD. So I'm not sure if a normal EGD would rule out a structural problem. Having said that, could this be an atypical presentation of a motility disorder? I'm not particularly sure. And I would be thinking, what would be the next step if we already have a normal, like an EGD that didn't reveal malignancy or a structural problem? Should we pursue the other diagnostic procedures, maybe looking for more of a motility issue? I'm not exactly sure. So those would be my thoughts.
Yeah, I love the way you're thinking. And I think I similarly, hearing, her age, her risk factors, was definitely thinking of a like esophageal mass or cancer, or something that we would see within the lumen. And I think important to step back and remember that within like structural causes, we can think of intrinsic. So kind of like you mentioned, rings and webs, and like masses causing structural like difficulty of like swallowing, or like kind of dysphagia, but also extrinsic causes as well. And so thinking about like mediastinal masses, increasing the left atrium size, or other extrinsic causes, structural causes for dysphagia. And so I love your idea of kind of expanding beyond like an EGD and thinking about other imaging modalities to further kind of evaluate and work up potentially extrinsic causes for her dysphagia.
And notably, Emma, I think, and correct me if I'm wrong, Lindsay, you only said that the EGDs showed normal mucosa. You didn't say anything else about that, right?
Right.
Like,
But
no,
that means I wasn't trying to trick you. That when they went in to do the EGD, it was normal. They didn't see any abnormalities. No tricks here. Just a tricky case.
Ah.
I will hot potato it to both Mario and Drew in terms of thinking about next diagnostic steps. What you guys think you would want to get next to kind of further work up for dysphagia.
Well, I think that was just such a good idea. I think that dysphagia really, at least for me, makes it just makes me think just of the esophagus, but not the surrounding structure. So yeah, the left atrium causing, I think it's called Order syndrome, can cause esophageal symptoms. I think if we're thinking of an extra or extrinsic cause causing esophageal compression, maybe a CT could be a good diagnostic tip, because mediastinal lymphadenopathy probably could cause esophageal compression and cause these symptoms. So I think a CT could be a good next step. I'm not sure what your ideas would be, Drew.
I mean, at this point, I'm thinking both bariums, probably a CT with oral and with oral contrast to see the lumen of the bowel, and maybe a barium swallow to get a better picture of the esophagus. Because I agree, if we're not seeing anything intrinsically wrong with the esophagus, we have to look outside. Or we have to think about a functional disorder, a motility disorder that may be masquerading as mass effect, or a functional dysphagia that would basically be, all else fails and we don't find anything. That's the diagnosis of exclusion.
Great job, guys. So she had both. She had a modified barium and a CT. The modified she had a regular barium, not a modified. The regular barium showed contrast stasis in the mid-esophagus. And then the CT scan showed bulky mediastinal lymphadenopathy that was causing extrinsic compression of the esophagus.
And biopsy of those lymph nodes showed.
What are your guesses?
Hodgkin.
Okay. Anybody else want to throw one out there, either in the chat or somewhere else? I see a lymphoma, granuloma. All right, it was small cell lung cancer. So the patient did have chemo and ended up doing well. I haven't followed up with them in a couple of years, but ended up doing okay. But I think one thing that Emma and I wanted to definitely show today was kind of the difference in motility case, which is the first case, versus a structural case in the second case, and kind of show the differences, but also how difficult it can be to kind of differentiate motility versus structural, especially if the patient's not clear. In our second case, we knew it was clear, structural. This is kind of like what we thought was going on. And in the first one, it's not clear. And sometimes it's like that. Sometimes it's not clear. And sometimes it's clear as mud. You're like, I know this is structural. I know what I'm looking for, what I'm prioritizing. And don't forget about those external compressions too. Emma, any other thoughts, reflections?
No, I feel like we kind of covered a lot of it throughout the course of both cases, but I definitely agree. And I think also to Mario's point, like if it is EGD negative and we're not able to find structural, intrinsic or extrinsic structural, actually going back to motility as a potential cause for what we think is a structural like dysphagia, but really just highlighting the nuances of dysphagia overall, and hopefully making dysphagia easier to swallow.
Love it. All right, take it away, Rafa.
Also, first, thank you, Lindsay. Very nice cases. I really learned a lot. Thank you, Drew, and thank you, Mar, for participating with us today. So the biggest shift complaint here that we discussed about was about dysphagia, and then Lindsay reminded us we have to clarify it first. Is it dysphagia, or it means difficulty with swallowing, or gynophagia, pain with swallowing? And dysphagia can be a structural or motility abnormality. So we have to go after any associated symptoms, including red flags. For example, in the side of smoking, weight loss, we could think about esophageal cancer. And it's also important to distinguish in the side of dysphagia oropharyngeal from esophageal dysphagia. Oropharyngeal dysphagia patients have difficulty initiating and swallow. When it comes to esophageal dysphagia, patients have difficulty swallowing several seconds after initiating a swallow. And then there's this pearl that food impaction is the most common cause for acute onset dysphagia in adults. And dysphagia to solids and liquid from the onset, we have to think about motility disorders. And when there is only to solids, we have to think about structural causes like a structure. And then we saw that this patient actually had achalasia. Achalasia means that there's loss of peristalsis causes mediastinal esophagus with failure of the lower esophageal sphincter due to the degeneration of neurons in the mesenteric plexus. And this is important to diagnose because it's an increased risk of esophageal cancer. And then on the second case, we started with chest pain, and we have to remember that 4+2+2 when it comes to chest pain emergencies, being 4 causes of cardiac like ACS, aortic dissection, tamponade, toxotubal, pulmonary cause like pulmonary embolism and pneumothorax, and in the setting of this case, esophageal causes with rupture and impaction. And then when it comes to esophageal cancer, something that we were thinking in the beginning, we have to see if this patient had rapidly progressive dysphagia, for example, initially from solids and later for liquids. We'll have to look for any other red flags like anemia, significant weight loss, if this is a whether the patient smoking history, chest pain, or gynophagia. And then in the end, we saw that the EGG showed a normal mucosa, and we have to think about extrinsic problems. For example, left atrial dilation instead of a mitral stenosis, for example, or mediastinal mass. In this case, it was a small cell lung cancer, but we'll also have to think about lymphoma. Or then we have to go back to the beginning, just like Emma taught us, thinking about a motility disorder. So thank you, everyone. This was such a nice presentation, and I hope to see everyone tomorrow.
Bye, everyone.